active ophthalmology intervention is required or has been done, then probably 2 to 4 monthly checks are important. And if there is worsening, then of course every 3 to 6 months. And in a limited care setting, you might use a direct fundoscopy, and if you are trained to use the fundus, and if there is a physician who can do it, then he could do it with a dilated pupil performed by a healthcare team who can be trained. Alternately, it can be referred to an ophthalmologist if there is a suspicion. Check visual acuity, review referral and preventive therapy areas of just like in recommended care. The frequency of examinations might become lower, maybe once every 2 years if there is no apparent reason or symptoms because of the limited resources. And wherever required, referral to an ophthalmologist. Next slide. So that was how you screen for detecting retinopathy early. We are not getting into the management here at all. We are only looking at screening in my talk. Now, the next is the diabetic kidney disease, what used to be called diabetic nephropathy. According to a study, most common cause of ESRD in most Asian countries, including India, is diabetes. And renal involvement actually has a multiplier effect. It also increases the cardiovascular mortality along with kidney failure and overall mortality. Next slide. So it's important to detect this early. These are the risk factors. Just to understand, more than 50 years, longer duration of diabetes. What is important here is if somebody doesn't have nephropathy for, let's say, 25 years, unlikely to develop it. Generally, in the first 10 to 15 years, after 15 years, the frequency declines. But after 25 years, if nobody has had any evidence of diabetic kidney disease, it is unlikely that he will develop because of various factors, including genetic. And as I said, genetic predisposition is important. Some genetic polymorphisms are associated, and therefore, if that predisposition is not there, despite diabetes, one would not develop diabetic kidney disease. Next slide. Also, hypertension. So you need to control blood pressure, therefore, to prevent nephropathy. It's one of the contributing causes. Hyperglycemia, we all discussed. Any A1C of above 11%, increased chances. If it's less than 8, chances decrease, but it's not that it's eliminated. So we need to get it. And as I've told you before, the 2 studies, intensive control can reduce the complication of nephropathy by 50 or 35%, depending on whether you're type 2 diabetic, type 1 or a type 2 diabetic patient. Once overt nephropathy, especially with loss of kidney function, is seen, then it is very difficult to reverse or halt the progress. So therefore, the entire mantra is preventing nephropathy. Next slide. Smoking, of course, as for any other condition, it's also a risk factor for kidney disease, and therefore one should cease to smoke. Next slide. Regular screening, therefore, is important because of all these reasons which I mentioned before. Next slide. And what do we recommend? Kidney function should be assessed at diagnosis. All patients of type 2 diabetes must be assessed at diagnosis. In type 1, it doesn't matter. It may be done after 5 years of diagnosis. But in type 2, every patient should be assessed at diagnosis and annually thereafter. And what do we look at? Urine test for albuminuria, we'll talk about in a little detail. And also measurement of serum creatinine for the kidney function and calculation of eGFR. So these are the 2 main things which are the cornerstones of screening for diabetes, kidney disease. And urine albumin is actually done through what we call a urine albumin creatinine ratio. These days, this is the recommended test. Wherever available, this should be done. If you have a facility to measure microalbumin, then you have to do a urinary ACR or albumin creatinine ratio, which is done as a spot sample, maybe early morning, but even otherwise is okay. And sometimes this can be done even as a side point of care test. Control the hyperglycemia. Of course, you should not have any infection, and you should not be really uncontrolled, and you should not be exercising, because that itself can cause albuminuria. And once these things are taken care of, and if you have a value of ACR more than 30 milligram per gram creatinine, then that could suggest a kidney disease. And if confirmed over the next 4 months, when you need to repeat this at least twice more, up to twice more, and at least is repeated once more if it is confirmed in the next 4 months in the remaining 2, that would suggest a diabetic kidney disease. Next slide. And microalbuminuria is confirmed, as I told you, on repeat. And if the ACR is more than 300, that is actually that is macroalbuminuria. That means this can be detected even by a dipstick method of urine testing. That is actually a macroalbuminuria or gross albuminuria. Diabetic kidney disease can also be diagnosed regardless of the albuminuria status by looking at GFR. The GFR of less than 60 ml per minute per 1.73 meter square, and this is calculated GFR, eGFR. And this is the method that are formally available through the net, and it can be done easily once you have the serum creatinine, age, and a few more parameters. It can be easily calculated. It's mandatory, and it's recommended that everybody, wherever he is or whichever setting he is practicing in, this formula can easily be applied. And one should calculate the eGFR to determine whether the eGFR is less than 60, in which case he's labeled as a diabetic kidney disease. Next slide. Yeah, so this is fine. Next slide. We need to measure serum creatinine also annually. Rule out non-diabetic kidney disease. All kidney disease is not diabetes in a diabetic individual. Therefore, you should look for some telltale signs which are mentioned here, and then look for other causes of kidney disease also. Next slide. In limited care, what do? You may not have facilities for microalbuminuria testing, so check annually for proteinuria, dipstick proteinuria. And this can be done in an early morning urine sample or even a random sample by a dipstick. And if it is positive and you have ruled out UTI, then this could suggest kidney disease in a diabetic individual. And if confirmed, it would probably make you think of diabetic kidney disease. Creatinine and eGFR is done just as for the recommended care. A simple inexpensive screening procedure is for urine protein excretion, which can be used as a diagnostic test, is known to all of us. So we could estimate proteinuria wherever other microalbuminuria cannot be tested, and then follow it up serially. Next slide. Now coming to neuropathy. 60 to 70% of people with diabetes have mild to severe forms of nerve damage. And therefore, they have several symptoms which are listed on the slide. And as I said before, more than 60% of non-traumatic lower limb amputations occur among people with diabetes. Next slide. And these are the various risk factors. Apart from blood glucose control, which has to be strict, the longer the duration of diabetes, the greater the risk for neuropathy, just like any other complication. Damage to blood vessels can also affect the nerves. Injury to the nerve, genetic susceptibility, smoking, all these are aggravating factors. Next slide. And these are the various types of neuropathy. I'll not get into the details of these, but if you start examining them, you can have different distributions that can manifest. Next slide. So what do? How do you assess? All patients with type 2 diabetes mellitus should be assessed for diabetic neuropathy at the time of initial diagnosis and annually. Largely, it is a clinical examination. You don't require too many tests. Even the tests are clinical examination with a few tools. So diagnostic sensory motor damage by history and examination. 10-gram monofilament is one of the useful tools for measuring, pressure sensation, and you might hear more of this in the next talk, because it's the simplest way of detecting loss of pressure sensation and risk for a foot injury or a foot ulcer. And it's not very difficult, and it should be made available, if not already, even in primary care settings and even resource limited settings. Non-traumatic pinprick vibration with the usual 128 hertz tuning fork, ankle reflexes, and if possible, with semi-quantitative methods of measuring the vibrations by what we call a biothesiometer. These tests are not mandatory, but they may be required and help you to determine that neuropathy is only because of diabetes, not because of any other cause. There are two scoring systems, again, a questionnaire based. This can be used at any setting, what we call the NSS and the NDS in the type 2 diabetic formulary, which is found to be a useful resource and can be a bedside tool. Wherever you have time, you can easily use this, even in limited care. Next slide. Next. Yeah, so in limited care, it's the same thing. I said that 10-gram monofilament can be made available even there. NSS and NDS is not difficult to get even in those resource limited settings. And then, of course, once you look for it, management is primarily for the pain and control of blood glucose. Next slide. So that was neuropathy. Now coming to heart disease. Cardiovascular risk factors must be assessed in all diabetic individuals, whatever be the setting. So for in that you look for dyslipidemia, hypertension, smoking status, family history of premature coronary disease, presence of albuminuria. We said that that can predispose to cardiovascular mortality, obesity, presence of hyperuricemia, longer duration predisposes, presence of retinopathy doubles the risk of CVD, and sleep also should be assessed. Heart failure, I'm not mentioning in detail in this talk because it is coming up recently, and in primary care settings, it will be difficult. All you need to do in primary care settings is probably to identify patients who have symptoms of heart failure and seek cardiovascular consultation. Beyond that, we'll not get into the screening. Next slide. So current or previous CVD events must be documented. Age, body weight, BP, pulse, all of them are important in not only the first visit, but in subsequent visits. And you can use sometimes these tools which are available, particularly the QRS3 for Indians is supposed to be a little better. And you can calculate the 10-year risk of cardiovascular mortality. And this is not too difficult in district settings as well. Next slide. So even in limited care, therefore, you can look for albuminuria if possible, hypertension, cardiovascular risk factors should be assessed properly, and if a tool is available, look at the 10-year risk. Next slide. This is a recent thing which you added, and I think 4 or 5 slides are left after this. The non-alcoholic fatty liver disease coming in a big way, in fact, part of the program as well, I'm told. And therefore, I thought that one slide should be important. The ASLD guidelines recommend evaluation for NFLD by measuring baseline and yearly liver enzymes. So liver function tests are important, particularly the enzymes. And a referral, wherever they're elevated or worsening, you should refer to a suitable center. They say that high index of suspicion must be there for NFLD and NASH in patients with type 2 DM. This is now called MASLD, of course. And they recommend the use of non-invasive measures for fibrosis, also what we call a FIB score. Not get into the details of that. This can not be done with simple tests. You don't require very complicated measurements for this. And but there is no clear-cut consensus as yet as to how much it should be used and what should be the cutoffs to refer to a specialized center. In general, a FIB score of 1.3 or more should undergo further evaluation by a liver specialist. Next slide. And I think the last few slides, just 2 more slides. Apart from monitoring for complications, which we've broadly covered the important complications, you also need to monitor for hypoglycemia, because that itself is although it's an acute complication, it can predispose or worsen so many other chronic complications. And therefore, the risk of hypoglycemia should be assessed during every visit in patients with type 2 DM by using questionnaires or select questions. The patient should be well educated and informed regarding the symptoms, causes, risks of hypoglycemia. So patient education is extremely important. Usage of SMBG tools wherever available with frequent monitoring, especially in insulin users, and insulin dose adjustment, looking at those values. So one has to be educated on all these aspects, and the physicians at the primary care level also need to be empowered to that extent. Strict monitoring of hypoglycemic episodes is recommended wherever patient is on insulin, sulfonylureas, or meglitinides, alone or in combination, because all these things can result in hypoglycemia. Other newer agents do not cause hypoglycemia. And therefore, whenever you choose the modern insulins or sulfonylureas instead of the traditional ones, and they will have a lower risk of hypoglycemia. Limited care, next slide. Yeah, again, all patients with risk of hypoglycemia should be inquired about symptomatic and asymptomatic hypoglycemia at each visit. Patient and their family members should be well educated about identifying hypoglycemia, especially nocturnal or nighttime hypoglycemia. And hypoglycemia should be strictly managed along traditional lines and particularly monitored in the elderly, in pregnant individuals, because that can cause pregnancy loss or fetal loss, in patients who are fasting, if at all they don't listen to your advice, and those with metabolic disorders or cardiovascular disease where hypoglycemia can be sometimes fatal. And therefore, in those individuals particularly, you should monitor hypoglycemia to the extent that you can. So what we've done in the last 20-25 minutes is given an overview of why monitoring is important in a diabetic individual, what are the components of monitoring, which includes glycemic or glucose monitoring, either through HbA1c or self-monitoring through a glucometer or through laboratory glucose estimations, and non-glycemic monitoring, where we monitor and try to identify complications as early as we can through regular screening, because several of the complications may be asymptomatic, and that may be the time to detect those complications and be able to help the patient prevent or the progress of those complications or even reverse them if possible. And I think that's where we'll stop. And if there are any questions, I'm willing to take it. Thank you.
Thank you so much, sir.
This is just a repeat of summary of what.
Thank you so much, sir, for the informative session. Moving forward, I would like to invite Dr. Nobojit Roy, Program Head Global Surgery and Trauma, the George Institute of Global Health. Dr. Nobojit Roy.
Just a minute, Siddhi. Dr. Madhu, you would be staying till the end of the session?
I would prefer to have the questions right away, because I got stuck in traffic and I just reached 5 minutes before this session. I still need to have lunch.
Siddhi, Dr. Nobojit, can we take few questions right now? I think there are 3 or 4 questions here. We can quickly take. One is about the BMI. What is the cutoff value?
The cutoff value of BMI in Indians is, for overweight, it is 23, and for obesity, it is 25. So anything less than 23 will be normal. 23 to 25 will be overweight. Anything above 25 is obese. Those are the cutoffs for Indians.
Okay. 18.5 to 22.9 would be normal.
Correct.
Okay. Okay. Can we consider cutoff BMI more than 23 instead of 25 years? I think you have answered that question already. Then hypoglycemic questionnaire. If you can you help them with the link for the hypoglycemic questionnaire?
There is not much in that. It's just that you need to inquire about each symptom of hypoglycemia. Many of you would be aware of what symptoms occur when patients develops hypoglycemia. For example, the patient can have palpitations, sweating, blurring of vision, headache, restlessness, excessive hunger. All these are symptoms. The questionnaire will have just a list of those symptoms in yes or no format, and you need to identify and ask the patients in detail any or all of those symptoms of hypoglycemia. In addition to that, you need to ask about the circumstances that could have led to the hypoglycemia. For example, is the patient on any drug which can actually cause hypoglycemia, or is not on that? For example, some of my patients come and tell me that I've had hypoglycemia. I have low sugar. I've not measured it, but I think I've had low sugar. But when you check the treatment, they are neither on insulin nor on drugs that can cause hypoglycemia. So that symptom is because of something else. So that question, whether he's taking, for example, as I said, sulfonylureas or meglitinides, which are secretagogues or secrete insulin in the body, from the body, and insulin itself, they can cause hypoglycemia largely. And so that history you need to take. And then whether the patient exercised unaccustomed exercise on a particular day, ate less on a particular day, or took inadvertently an excessive dose of the medication that he's been taking on that day, that could have led to hypoglycemia. This again has to be inquired. And finally, any other drug that can be taken for a coexisting condition which can interact with these drugs or itself cause hypoglycemia, which can also predispose. So these are the things essentially which form the questionnaire.
Then there is one question on why there is no plan for dressing as per TVN considering regular debridement.
This, I think I'll leave it to the next speaker, because he's going to focus entirely on the foot and the wound management. So let's leave it for the next speaker.
Can I ask you, Dr. Madhu? I think one of the reason is the insulin, high dose or a low dose. How do you adjust the dose? If you can, quickly address that, adjustment of a dosage of insulin.
Okay, the adjustment of the dosage of insulin depends on what is the insulin regimen that the patient is on. in a type 2 diabetic patient, the first thing that we do when patient fails oral agents is add a bedtime basal insulin. So how do we monitor such patients? How do you adjust insulin in such patients? Having started, generally we start by 6 to 8 units of an intermediate acting insulin like Glargine. And we adjust by looking at the fasting blood glucose, because the action peaks around about 10 to 12 hours, lasts for about 18 hours or so. And therefore, if you give it at bedtime, all you need to do is check the fasting. And if the fasting after 3 days, let's say today night you gave a Glargine, and day after tomorrow onwards, you check the fasting, and the fasting is not in target, then you increase the Glargine that night by 2 units, and that way you go on adjusting the dose till you get the fasting in place. This is for a Glargine intermediate acting. But if somebody is on, let's say, basal bolus regimen, as we call it, like intermediate acting insulin at bedtime and a prandial insulin, that means insulin with each meal for the postprandial spike of that meal. One before breakfast for breakfast, post-breakfast glycemia, one before lunch, and one before dinner, respectively. There, the adjustment is a little different. For intermediate, it's the same. The intermediate bedtime is adjusted based on the fasting. However, the prandial doses are adjusted based on the postprandial peak. A post-breakfast peak will decide how much of pre-breakfast prandial regular insulin you will give. And likewise, the post-lunch peak will decide what level of pre-lunch insulin you will give, and the post-dinner peak will decide the pre-dinner dose. And how do we adjust? Each increment normally should be about 2 units at a time, not more than that per day, unless the glucose values are really high, let's say 300, 400 plus, and then maybe 4 units is justified. But otherwise, each increment should be by 2 units till you get the prandial glucose under control. I think if there's anything else specific you want me to address, I'll do that. But this is broadly how we adjust.
Okay, I think because many times patients also don't, come report this, and we as a doctor also don't regulate the dose of insulin properly. So end result is that the patient remains in with high sugar for a long time.
Yes.
I think fasting blood sugar cutoff is, I think 126.
That is for diagnosis.
Yes,
The
and
cutoff
for
is
maintenance of
yeah, that we generally say the target for control, the fasting should be 110 to 115 milligram per deciliter. We're okay with 115 as well. And the post meal should not exceed 180. Normally, we recommend 140 to 160. 160 is good enough.
why microalbumin 24 hours is not used when it can better screen first, meaning higher sensitivity.
No, the problem with 24-hour collection is that the collections are variable, and you have to carefully monitor that it's actually 24 hours. It's not easy to collect a 24-hour urine sample. Instructions have to be very clear. There is variation of albumin secretion, microalbumin secretion, and so on. And therefore, the best way to do it is a spot. You do a spot urine microalbumin, and you also do the creatinine, and you measure and report the microalbumin as so many grams per gram creatinine, so many milligrams per gram creatinine. So that takes care of the need for a 24-hour collection.
Okay. The question is not clear. It says 2 hours PPS, how to treat?
2-hour PPS, what the question I think is, although my talk was entirely on screening for complications, but I'm open to answering this. See, 2-hour, basically what the questioner wants to know is how do we control postprandial hyperglycemia as opposed to a fasting hyperglycemia. That's what I think he's wanting to understand. There are certain agents, oral agents, which specifically target postprandial hyperglycemia. Among them are the DPP4 inhibitors. They specifically would target the postprandial, but also work on fasting. Then there would be other agents like GLP-1 analogs, again specifically target the postprandial blood glucose, but also affect fasting. And the third group is the acarbose, which again, targets the postprandial. So wherever the postprandial is a specific issue, that means the fasting is in target, but the postprandial levels are still high. For example, fasting is 115, 120 or 130, but the PP is 300. There you need to specifically target the postprandial glucose, and these choosing a drug out of these would be a good option. In insulin users, just by changing the prandial insulin, that will take care of the post meal peaks.
Next question is, in a hypertensive patient who develops diabetes later, can nephropathy set in earlier?
Yeah, I think I did mention that, in a type 2 diabetic patient, hypertension is one of the additional risk factors for diabetic kidney disease. In a type 1 diabetic, if you have hypertension, that is a consequence of diabetic kidney disease. Whereas in a type 2 diabetic, it's a comorbid condition which further predisposes to diabetic kidney disease. And there is therefore, for preventing kidney disease, you don't not only need to control blood glucose, you also need to, or perhaps more importantly, control the hypertension and the lipids.
I think next question is about the timing of the medication. The thumb rule for medication is 30 minutes before lunch.
I think there are two things to be addressed here. The before meal dosage is only applicable to those agents which act through the pancreas and secrete insulin, whatever insulin reserve is left. That means they're secretagogues like sulfonylureas or meglitinides. For others, this doesn't hold true. All other oral agents are given post meal. Only sulfonylureas, the thumb rule, as you said, as the participant said, is about half an hour before the meal, and also for meglitinides. But otherwise, no. Otherwise, you need to take it post meal.
How about timing of insulin?
Insulin depends on the timing is more important for the prandial insulin. It is not that important for the intermediate or basal insulin, because basal insulin is just setting a basal insulin level over a 24-hour period. Normally, if it's a glargine, we give it at bedtime, and bedtime is not pre-dinner. We actually recommend it to be taken at bedtime because that controls the fasting most effectively, and it has nothing to do with what you've taken in the previous dinner or any other meal. As far as the prandial insulins are concerned, the regular insulins are concerned, if you give a conventional regular insulin, it needs to be taken at least 20 to 30 minutes before the meal. And if you take one of the analogs like Aspart or Lispro, then a 15-minute or sometimes even a 10-minute pre-meal is good enough. And rarely in children we say even after meal, because there you do not know the intake, whether the child is going to actually take or not. So it's better to ensure that the child has eaten and immediately give the rapid acting analog.
Then regarding diabetic retinopathy, how much reliable is the fundus on phone for screening purpose of DR AI base? Is it validated?
It's absolutely validated. The limitations we should understand. We use it in our center. Ours is a tertiary care center, but here we screen for retinopathy only through a fundus and phone. And then after that, wherever required, we send the patient to ophthalmologist, because it also is difficult for ophthalmologists to see all the patients as a regular annual screen for all the diabetic individuals in the country. The numbers are huge. No ophthalmologist will be able to do. So we have to use this, and the AI is a good system, but only limitation is it will tell you yes or no. It is best, it will say no or yes. So if it is no, then you can just relax. If it is yes, then what type of retinopathy is there? For that, it is better to refer to an ophthalmologist and take his opinion.
How role of Monjaro in diabetes?
Okay, role of Monjaro. Monjaro is one of the important primary agents to be used in all type 2 diabetic individuals where the major concern is heart disease, kidney protection, or obesity. These three things must be there. Then this is one of the primary drugs, and especially in obese individuals, let's say the BMI is more than 27.8, or some people say 30, but 27.5. And any diabetic who is above 27.5, this becomes one of the important agents to use. And it has a role in obese type 2 diabetic individuals, especially if they have heart disease, or there is a high risk for heart disease, or there is, let's say, some evidence of early kidney disease you want to prevent progression.
I think the other questions are more on the management of starting. When do you start with insulin? When do you add, insulin to the already regimen?
We could have a separate session on management later.
Yeah, I know. We've had this, for your information, we had this diabetes session. Recordings are available on the YouTube channel of NHSRC. I think I would suggest you to look into that, because there is, each one of them is important. How do you manage hyperglycemia? How do you manage hypoglycemia? And then how do you take the decision when to start with insulin? All those answers can be, found on those recording. In fact, all previous sessions are available on the YouTube channel. So we will urge you to go through those recordings. Thank you, Dr. Madhu, for patiently, answering the questions.
My pleasure.
And that even I also got stuck in traffic today. It took me more than 2 hours to reach home.
It took me more than 2 hours to reach home. That's exactly the point.
Yeah, I had to also detour and somehow just managed to reach home by 3 o'clock.
Okay. Thanks a lot.
Thank you very much. Thank you.
Thank you.
Okay, Siddhi, now we can move.
Thank you so much, sir. Moving forward, I would like to invite Dr. Nabojit Roy, Program Head Global Surgery and Trauma, the George Institute of Global Health. Dr. Nabojit Roy, MS, MPH, PhD, FCS, is Director, WHO Collaborating Center for Emergency, Critical and Operative Care at the George Institute of Global Health, Program for Global Surgery and Trauma. He is also the Professor of Surgery and Chair of the Center of Leadership at the University of Global Health Equity at Kigali, Rwanda. Prior to this, he was the global lead for surgery and anesthesia at the WHO headquarters in Geneva. In the Belly and Love Short Practice for Surgery textbook, Roy sir has also authored a chapter on his work as a community surgeon for 2.5 decades. Before he moved to NHSRC Ministry of Health of India as the National Advisor, Public Health Planning and Evidence. He has been the Lancet Commissioner for Global Surgery 2015 for NCDs and injuries in the poorest billions 2020. Over to you, sir.
Thank you so much. You can see my slides. And thank you, Dr. Jayan Srivastava, Dr. Sharma, and Dr. Ranjit, Siddhi, Deepthi for your help from NHSRC. Much obliged. Thank you. From Dr. S.V. Madhu's talk, I am moving to the aspects of management of diabetic foot and preventive care. I hope to be joined by my colleague, Dr. Arun Bal, who was a senior expert in diabetic foot. It is often said that time heals all wounds, except the diabetic wounds. It's a bit sad, but that's the way it is. Just with time, diabetic wounds do not heal. In fact, it progresses. And many of us have had that personal experience with our patients. The diabetic foot burden fact sheet. Here are a few facts about diabetic foot. Diabetic foot is the commonest complication of diabetes needing admission. 30% of admissions are due to this complication of diabetes. Diabetic foot healthcare costs are more than any other diabetic complications, which is about 20%. So it's a very expensive disease. 85% of non-traumatic lower limb amputations are because of diabetic foot. And madam, you have raised your hand. Oh, sorry, it must be a mistake. No worries. Every 20 seconds, a limb is lost in the world somewhere. 45,000 lower limbs are amputated in India every year. And the saddest fact is that if you've had a major amputation, within 2 years, 50% of the same patients will also have the other leg amputated. These are the sobering facts about diabetic foot. Overall, 40% greater risk of dying than in patients who have just diabetes alone, and in 10 years. And it all starts with an ulcer. The thing is that by the time this patient comes to surgeons like us, it is already usually too late. So actually the whole treatment is in the hands of this entire audience of 350 people. And I must say mainly nurses, because they are the ones who are going to be able to detect, pick up and manage these feet before they come to me, mainly for amputation, which is very unfortunate. This was the standard treatment guideline that with Dr. J.N. Srivastav of NHSRC, we had done for the Ministry of Health in 2017. It was based on the NICE UK methodology. NICE is the National Institute of Academic Excellence, Clinical Excellence, in the UK, which has given us the methodology. In 2022 July, for PMJ, for the Niti Aayog, we had converted this standard treatment guideline to a standard treatment workflow. All of this are publicly available, and if they are not available to you, we can make them available, because this is the standard Ministry of Health guideline for diabetic foot. There are a few pathways which we enlisted in this guideline. So the first in the foot care of diabetes is, how do you take care of the feet? Second is, how do you reduce the risk of the diabetic foot problem? And third is, how do you manage the diabetic foot problem? And you can see that managing diabetic foot problems surgically is a small part of the overall treatment of diabetic foot. So from the ulcer, how does it go to amputation? There are some things that diabetes does to the foot. First is peripheral arterial disease sets in. There is lowered vascularity. The foot does not get enough blood. There is ischemia. The second thing what diabetes does to the foot, as Dr. S.V. Madhu also had said, is neuropathy. So there is loss of pain, and pain is a protective sensation. There is loss of protective sensation. There is deformity of the foot that sets in. The joints become rigid. The skin is dry, and there is decreased integrity. At this point, all of you, all 350 of you, are seeing the foot. And this is the time where we can do something, because all these patients are walking barefoot. That's the culture. They are not feeling the pain, so they don't have any need to wear any footwear. And also, we are not aware of this problem, that this is going to finally escalate to an amputation. So the unnoticed repetitive trauma, improper loading is how the weight on the foot is balanced, and abnormal plantar pressures, because there is one side of the leg is bearing more weight than the other, or the ulcerated part is bearing a lot of weight. Cracks and fissures start appearing, and then we have the ulcer. The ulcer does not look very dangerous. It is an innocuous ulcer. And this is the herald, the sign, which eventually is going to cause the downfall of the patient. With neuropathy, repeated trauma, and inflammatory reaction, the Charcot foot sets in. The Charcot foot is a neuropathic foot. It has osteoarthropathy in the foot. And that is already quite a deformed foot. And diabetic patients have these deformed feet. How do the deformed feet look? They look like this. There are hammer toes, claw toes, hallux valgus, pes cavus, rocker bottom foot. You can just look at the feet and say these are not normal feet. And these feet, if we don't look after them, they will slowly progress. Then the final stroke, infection. Once infection sets into this foot, then that is the rapid downslide because there is already diabetes and now there's infection. Early infection, it's mild gram-positive infections. Then it rapidly progresses to Pseudomonas, and that's when the danger really sets in. So a combination of antibiotics given early and care of the feet normally stop the progress of the diabetic foot infection. Gangrene follows very rapidly. This is chronic gangrene. Sometimes we even have acute gangrene. You'll have all seen this. And by this time, there is nothing left for the surgeon to do except to amputate. So that is the journey from the foot ulcer to amputation. So what do we do? The emphasis is always on prevention and educating the diabetic foot patient, then assessing the risk. We follow them up frequently, manage the risk, and finally, it is the diabetic foot management, which often has to be done in a diabetic foot clinic or in a tertiary hospital. So what do we do in terms of education and foot care? The magic word is called offloading. We have to get weight off that ulcer. The diabetic patient will walk on the ulcer because he or she feels no pain. That is the reason why we need to offload that foot. We need footwear. Sorry. Balsar, you'll have to go on mute, sir. Thank you. Then we have footwear, feet care. What do we do with feet care? We encourage the patient, and every time the patient comes to us, also in the clinic for diabetes or any other problem, we request inspection of both feet, that preferably done daily by the patient. They look at the area between the toes for blisters, cuts, scratch, or sores. This is the starting point. We encourage them to wash their feet daily with water at room temperature. Carefully dry the foot, especially between the toes, where we get a lot of fungal infection otherwise in diabetic patients. We encourage the use of lubricating oils or creams for dry skin, but we tell them not to put it between the toes. We encourage them to cut their nails straight across so that there's no ingrowing nails. And we encourage them not to use any plaster or chemical agents to remove corns and callosities. Best taken off by blunt knives or scissors. Most importantly, what even healthcare workers do not know, and patients definitely do not know, is that we cannot use hydrogen peroxide, we cannot use Usol, and preferably we should not use even betadine ointment for these wounds. Now this comes as a surprise. Actually, the foot is so sensitive, so devascularized that any of these strong chemical agents will flare up the infection. You will think that, oh, I just did a dressing. Next day, the patient is coming with gangrene. And you said, how is this even possible? That's because the foot is so sensitive to these very harsh chemicals. So what should we do dressings with? Actually, the agents that we recommend are clean water What is the definition of clean water? Boiled and cooled water is clean water. We do not need distilled water or normal saline. That is actually the only thing that the delicate diabetic foot can manage. The other thing which we use often is special sandals, shoes, or we use a total contact plaster if we do not have shoes and special software. These are how shoes look or sandals look for diabetics. You can see that there is the front part of the heel is missing. So if you have an ulcer in the front, you offload that part of the foot and all the weight is carried by the back end of the heel of the foot. If you have an ulcer at the heel, which is also very common, you just shave off the sole from the back and then you have offloaded the foot. These are not pretty shoes, but this will save the limb and the life of the patient. Moving to the assessment and care pathway. Firstly, we need to do a general assessment of the diabetic foot patient. And if they have any signs of sepsis, the patient is visibly unwell, drowsy, has abnormal breathing, abnormal pulse, fever, this is bad news. We need to refer immediately. For the foot examination, we have to check for ulceration, rest pain, gangrene, cellulitis. The temperature of the foot is very important. If it is cold, pale, or dusky, it may indicate ischemia. If it is warm, red, or swollen, it may indicate Charcot's foot. Both of them, my friends, represent life-threatening problems, unfortunately. Lastly, as we've already covered and I've showed you pictures of, deformed nails, calluses, macerated web spaces, skin fissures, claw toes, hammer toes, rock bottom foot, all of these are placed telling us that the foot is not in a good condition, and this will, if neglected, will result in amputation. Next, we have to look for vascular and neuropathy. For vascular, just palpating the pulses is what we would recommend, because most of us work in district hospitals, most of us work in clinics, and a clinical examination is perhaps the best way to check. And second is a history of intermittent claudication. These two are enough to be able to determine whether this foot is compromised. Next is to check and screen for the loss of protective sensation. This is the test that Dr. S.V. Madhu was suggesting. All we need is a nylon thread, a nylon monofilament thread, and touch it to the patient's feet. And it's what is classically called a 10-gram pressure. We have to give it, test it. And that is the way to test at the periphery, at the clinic, at the Arogya Mandir. Just as Dr. S.V. Madhu said, this is such a cheap test that it's available. I can understand you may not have a bioaesthesiometer and a graduated tuning fork, but this is the bare minimum, and it is our job in the center to make it available to all these Arogya Mandirs. And this is how it looks. It's just a nylon thread, and these are the various points on the feet and the plantar region that we test. And if the patient is not able to feel the pain, feel the touch, that's when we get suspicious that the patient has started losing sensation, and very soon there'll be the ulcers coming along. How do we triage it? The green triage is low risk. If it's a callus alone, all we need is good glycemic control using the Dr. S.V. Madhu formula. We seek help, modify risk factors, and advise foot care. The medium risk is when deformity is setting in, there's loss of protective sensation, and there is vascular compromise. We manage peripheral arterial disease with statins antiplatelet agents, we prescribe exercises to improve circulation, and we can consider referral for further investigations and revascularization. And of course, the highest risk is patients where they have previous amputation or any of the two, which is loss of protective sensation, peripheral arterial disease, and lesions or deformity. So any of these two would warrant a routine referral, and that calls for foot protection services, callus debridement, nail care, wound debridement, and in the last cases, amputation. This, aided with vascular intervention, often helps healing of the wound. Else, often the diabetic wounds do not heal, as I had mentioned in slide 1. Low risk patients we need to see every year. Medium risk every 3 to 6 months, and a high risk every 1 or 2 months to prevent progress. So this is all a part of a BMJ clinical update, and it is available. Again, we will make this available to you all so that you are able to keep this, maybe print out the poster and know the pathways in a very simple format. This is how the visual summary looks. This BMJ clinical guideline was based on the Indian standard treatment guideline on diabetic foot. Lastly, surgical management of the diabetic foot. This is how the patient presents to us. It's only the tip of an iceberg. Next 4 slides may be a little graphic. So there'll be a bit of surgical surgeries shown. So please bear with me. Though this is the tip of the iceberg, what is seen below is something which is what is below this, which you will find on an X-ray. There is some amount that the bone has been eroded. You will find that the infection is spreading, and the correct end result is this after a good surgery. What used to happen earlier on when we were not trained in diabetic foot by Dr. Bal, we would first take the toe off, then the wound would not heal. 10 days later, we would see that the infection and gangrene has spread. Then we would do a metatarsal amputation horizontally. Then another 10 days would go by, infection has spread, wound is not healing. Then we would tell the patient again, we need more amputation, and slowly, bit by bit. And as Dr. Bal often jokes, the diabetic patient dies bit by bit. So we just, little by little, we are cutting higher and higher until we have reached below knee amputation. After 4 surgeries, patient is not doing well. Because the basic principle of diabetic foot is that it spreads longitudinally. It spreads not sideways, it spreads lengthways. And what we need to know is the compartments of the foot are central, medial, and lateral. And the infection is also spreading longitudinally. And that is how we need to actually cut open that part with the tendon. That compartment has to be laid open so that the pus comes out. The infection follows the tendon. So even if the toe is looking black, actually the tendon has carried the infection above the ankle. And unless we are able to track, trace, and chase the tendon, and that's why we call it tendon chasing, we will just keep cutting horizontally, and eventually the patient will end up with a BK amputation. Most of these surgeries can be done under local anesthesia. So it is very much possible to do it at the district hospital and in the sub-district hospitals. And we are able to give simple regional ankle blocks, and you don't even need an anesthetist to do most of these surgeries. Some more examples. Here is the example we are showing you. Here is a post-operative picture. Another tip of the iceberg. It looks as if it is a small wound in the toe. Actually, the infection has reached all the way to the green arrow. And just as we were saying about compartments, the surgeons or the practitioner needs to open it out, and then we need to lay it open and longitudinally, and that is how we manage to drain the abscess and the diabetic foot. The last thing is that obviously this talk of 20 minutes is too short to go into the surgical details, but there are longer courses available from most of the diabetic foot societies, and we help them actually optimize wound care. We have courses on offloading strategies, understanding surgical interventions, and also going into rehabilitation and decision making. This is currently beyond the talk which I'm giving now, but these courses are available. So the key takeaways. Firstly, we prevent the ulcer. And as I said before, the foot clinics actually can be run by nurses, by tissue viability nurses, and it can definitely be running in the Ayushman Arogya Mandirs. We tell the patient not to walk barefoot. We use offloading with sandals, and we can, if your sandals are not available, shoes are not available, then we can use a total contact cast. Please do not use Usol, hydrogen peroxide, and preferably no betadine. Clean water or saline dressings is the way forward. Surgery by longitudinal incisions under regional ankle block. Good news is PMJ covers this. There is a package in the health package benefits of 2.1. It's under plastic surgery SP 002A, and the reimbursement for surgery is 30,000. So there is allocated amounts for treatment. Also in the general medicine package, MG 58, there is admission for under PMJ for ICU care, because a lot of diabetic patients don't need just foot care, they also need ICU care, and there is provision in PMJ for that. Lastly, what is the future? Most of the prevention can be done by AI. AI is coming in a big way. There is Foot Snap AI, My Foot Care, DFU Care, all these clever apps which are being driven by the smartphone to monitor foot health. They help in detecting ulcers, and they can also give warning signs when the patient needs to see the physician. Thank you for listening to me patiently, and I'm happy to have Dr. Bal, and the questions are open for the diabetic foot team. Back to you, Deepti.
Thank you, Navneet. It was quite, I must say, you presented it well, but the visuals were quite disturbing. You know, when you see such patients, I myself being a diabetic for 30 years, I was little, my heart was sinking. Anyway, but proper foot care is the message here. Prevention is better than cure. And I think one most important take-home message is that we must examine the foot and ask the patient to examine his foot regularly and report even small lesions, callus, development, which you may, temper at home on your own. All that should be avoided. There are one or two questions here, Navajit. Dr. Arun Bal, would you like to add anything before we switch to the questions, or we... Yeah. Anji sir, good to see you here after a long time. Is he there? Okay.
I think he's struggling a bit with his microphone.
Okay. Maybe when
Sir, sir, you can also type it in the chat if you are having trouble, sir.
is varicose vein a risk factor for diabetic foot?
No, that's they can be they can coexist, but if they are not necessarily correlating with each other.
At a primary level, how shall addressing be done for a diabetic ulcer? I think you already addressed that.
Yes,
Normal
madam.
saline or water.
Yeah, yeah, that's right. And there are I mean all these more expensive dressings can be used, but honestly we don't necessarily have very strong recommendations for using silver colloid, bactigras. We can use them, but it's not necessary to have them in the primary level. That is the strong message that we wanted to give here based on current evidence. I know a lot of marketing companies are giving a lot of clever dressing material, but we don't necessarily need to use these compounds. Over. Yes, and as Dr. Anveshi Nayan says, role of silver dressings. Again, silver dressings can be used, but we don't want to use very strong anything. Basically, we don't want to promote one dressing over the other.
I think that answers this question. Any medicated gauze packing which can be of significance.
Exactly. So between saline dressings and these very expensive dressings, we do not necessarily recommend these expensive dressings, because moment these dressings get expensive, then the dressing doesn't get done because there is not enough money to buy these expensive dressings. So I would not recommend it. The point is to have this and offloading, because no matter what masala you put on the wound, it will not heal because it's not being vascularized. There's not enough blood reaching there. So that is the reason why.
I think this question, why patient always complains of pain and burning sensation at lower limbs. Some patients complain of pain while getting up in the morning on the foot and not able to walk for a few minutes.
Excellent question. That is mainly because of the ischemia. So it is the ischemia because the foot is not enough blood is reaching the foot, which is why they get what is called intermittent claudication. The recommendation is gentle exercise, keep walking, keep exercising in the bed and with walking until you start getting pain, then rest and then start walking again. That is the recommendation to improve the vascularity through exercise, which is the recommendation.
Then again, the question is about low alkaline soap like pears to clean diabetic ulcer.
It can be used. Anything that is mild can be used. But again, the excitement about using something strong is always there. And what we realize is that anything which is irritant to the wound will flare up the wound. So, as I said, it does not matter what you use on the wound. It does not matter. It has to just remain moist and it needs to soak up the exudate. That is the only purpose of the dressing, to soak up the exudate so that it doesn't start getting macerated. When a wound gets macerated, it just gets worse. So you want it to remain moist because dry wounds do not heal. And you want it to be dry enough for it to soak the exudate so that the wound gets a chance and a normal, happy milieu to start healing. Again, it's not that only. Wound care has to be accompanied with antibiotics and it has to be accompanied with offloading. So these are the three triad of treatment.
The next question is about corn in diabetic patients with minor pain occasionally. Then what will be the management?
Excellent question. A corn is like a stone in the shoe. A small stone, when we get it in the shoe, you know how much it hurts. and the diabetic patient will have a stone in their shoe and they will not complain because they cannot feel the stone. You know how tragic that can be. Similarly, a corn is like a stone in the shoe. So he'll keep walking, or she will keep walking on the stone, which is the corn, but will not feel it. So it is our duty as healthcare professionals to use a flat knife and gently shave it off. We should not use those corn caps or anything that is very strong. So the best way is to use a big, large, flat scissors to cut the corn off, or just a flat knife to cut the corn off and level it off so that the stone in the shoe, which is the corn in the shoe, is taken care of. So it is an outpatient procedure. It can be done at a clinic level. Definitely it can be done at a sub-district level for sure.
Frequency of dressing. I think, sir, आपका दो devices on है. That is why it is echoing. So you have to switch off, mute one device.
Sir is only on one device. I don't know. He's having a bit of trouble.
But why is it echoing so much?
Yeah.
Every time he
I'll just continue with the questions, madam.
Sir, frequency of dressings. What should be the frequency of dressing? And is vacuum dressing helpful for diabetic foot?
Yeah. Excellent questions. Yeah. So, as MO, one gentleman MO said, local infection at site with saline packing. That is it. It is actually a good way. Local infection will get controlled with saline packing. Local antibiotics are not of very use. You will have to give systemic antibiotics, which will take care of it. Is it required open dressing, closed dressing? Definitely closed dressing is preferable. Faster wound healing. Is it okay to prescribe Lim-C, zinc, protein powder? Yes, by all means, you can prescribe it. Proteins are required for improvement of the wound healing. So hypoproteinemia, low proteins does not help the wound heal. So by all means. Tabtrypsin, we are not very sure. There's not enough evidence for tabtrypsin to be used, but I know a lot of people use it. Then diabetic foot vacuum dressing, is it useful? Foot vacuum dressing is useful. So anything that is taking the exudate out is good. And then you cover it with a total contact cast, and then no need for dressing for a week. That is also possible. Yes, Dr. Lepcha, there is no nylon thread. Yes, it is our duty to reach the nylon thread to you, and we will do that. And we have tried to get this nylon thread to all centers, not only in India, but across the world. And that is what we try and do. And yeah, is the prevalence of diabetic foot decreasing? Sorry, Dr. Sushil Chauhan, it is actually increasing. We need a lot of help. I'm so sorry about that. Yes.
Diabetes is increasing. More are the number of uncontrolled diabetes. So it's a natural long-term complication. So we don't.
And 6 to 10% of all diabetics will have diabetic foot. So it is a very huge burden. I have been non-stop trying to answer questions, Dr. Sangeeta, so I'll hand back to you.
Thank you for taking up. I think this was very, very useful, and people at periphery always thought that they cannot handle diabetic foot, but certainly they have a very significant role to play, prevention, and then taking care of, if something starts coming up, and timely referral to a surgeon is very important here. Once it is a very bad wound, gangrenous already, perhaps you also must be feeling very sad that you cannot help the patient very much. I think I'll now move to my session. If you like to stay back, you're welcome. But what is it? The time in Ghana now?
Sir, madam, it's 1:45 in the afternoon.
Oh, okay. Good enough. So I was thinking it should not be a late evening or something for you. Okay, let's. Okay, I'll now briefly talk about how do you optimize drug use, and particularly my focus area is insulin, and sometimes errors with the medications. Oral hypoglycemic agent can cause harm to the patient. So I'll this happens more than expected. Many a times we are the cause of any adverse event happening to the patient because of our management was not proper, and the magnitude of such harm is huge. It is, in fact, it is called hospitals are more dangerous than air travel, and we saw how devastating it was. The recent air crash, everybody on board died except one person, so fatality is almost 100%. So something like that, that kind of error happens. And one of the major medicine use is very common. Most of the accomplishments that we have in modern medicine are because of the medicine. We are able to control, cure diseases, but at the same time we must remember that they are double-edged swords. They can cause errors and cost us. And in terms of, if you talk in terms of quality and safety, you cannot separate them. They are inextricably linked. You cannot say I am NQA certified hospital, but such events happen in my institute or in my organization. So because most of the harm caused by medical practice is avoidable. I'm not talking about progression of the diseases. I'm not talking about complications developing during management. It is all, the wrongful or something act of commission or act of omission, that we were supposed to do something and we did not do for the patient, that causes harm, which is most is avoidable. And the key areas that where we need to be very careful about such errors happening is high risk situations, high risk settings like emergencies, ICUs, high risk patients, very elderly patients, very small neonates, young patients, pregnant women, and then high alert medication. These are associated with more number of, not necessarily these are dangerous drugs, but they are more associated with these errors and devastating effect on the people. And insulin is one of the most commonly used high alert medication that everyone, right from at all levels, are using insulin. So that is why I thought I will talk about insulin today. And then polypharmacy, whenever a patient gets more than four medications for management of a single illness, again, anytime if the number of drugs move to six, more than six, expect some adverse event, some ADR, some error to happen, some drug interaction to happen. So polypharmacy, as far as possible, should be avoided. But I'm not talking about people with multiple comorbidities. They may need it because they may, diabetic patient particularly, they may have other coexisting morbidities. So you need to take care of them. But remember, each time you add another medication to their regimen, please see to it that there are no drug interactions or adverse drug reactions which may complicate your treatment. Then transition of care is another place, time when most of these errors happen. By transition of care, I mean when the patients are being transferred from one patient care area in the hospital to another, like from IPD to ICU to operation theater, back to room, back to IPD, or at the time of discharge of these patients. At this time, more number of errors happen. This is largely because of increased risk of communication errors at these points. So because either there is a doubling of the medicines, duplication of the medicines happen at these times, or omission may happen. It happens very commonly. At least I have seen when these diabetic patient or any patient who gets admitted in the hospital for some other illness, at the time of discharge, they will write, continue your diabetic medicines or hypertension medicines as early, as earlier. And if this point is not clarified to the patient that they have to continue, many of them stop medicines, or they just go by the last prescription. So these are the times when you have to have a clear communication with the patient. Now these errors can happen at any stage of drug use, from prescribing to transcribing, dispensing, administration, monitoring stage. Insulin is one such drug where we have seen errors happening at all of these stages. So it could be a wrong patient, wrong drug, wrong dose, wrong type of insulin. It could be the wrong time, or omission errors happen, when you are supposed to take a medicine but you are not taking, or you are not advised to take that medicine. And monitoring and compliance error here again, whether the patient is taking insulin but we are not monitoring whether we are able to achieve adequate control of sugar or not. So insulin is one of the very important, most commonly used high alert drug. So these drugs, these high alert medicines, need to be double checked before they are administered, because they have a higher likelihood of causing injury if they are misused. A small overdose of insulin can lead to hypoglycemia, whereas at the same time underdose of insulin can lead to sustained hyperglycemia. So these are not necessarily more frequent, but whenever they happen, they are more devastating. Hypoglycemia is one of the very important, life-threatening, immediate complication that may arise because of the improper dose of insulin. So and one more thing very important with insulin is, we all know about the look-alike, sound-alike drugs. There are several thousands of such medicines which are available in the market. You can understand, you all know the consequences of giving these drugs in error. Lente versus lenters, there are various different types of insulin that are available. It is again, it is a high alert drug, as well as it comes under the look-alike, sound-alike drugs, because there are different types of preparations of insulin which are available. Plain insulin, regular insulin, NPH insulin, then analogs are there, then long-acting insulins. So these are there. So furthermore, one is that the confusion can happen between different types of insulin. Then second cause of concern with insulin is that there may be confusion between units and insulin syringe. How much units, which syringe should be used, and how much ml is equal to how many units. That confusion may happen. Sometimes patients do not understand that, and they may they may use any other syringe, or they may take, this may lead to or a overdose. And then third point, very important with insulin, is the technique, how to administer this. Many times, if a patient is not taught properly how to take insulin injection, again, it may not serve its purpose. Now, some of these problems of identifying the insulin types, these are taken care of by using different colors. Here you can see the cap colors are different, so each color signifies a different insulin type. Likewise, the cartridges that are available, you may find different color cartridges. the pen devices the patient are using. So you have to teach the patient that they should use that color. This color signifies, and they must stick to this color of the insulin. It is not that they can interchange on their own without without consultation. Then the other as you know, there are different types of insulin that are available. You should know the onset of action. Mostly the human insulin, like regular insulin and NPH, they are considered as the fast-acting insulins, whereas the analogs like Lispro, Aspart, Glulysin, they are little more faster acting. Than they have been modified in a manner that their onset of action is faster. Then there are long acting insulins that are available, which are used as a basal regimen because they have a long duration of action, like Detamir, this Glargine. So these different types of insulin. So you should also be familiar with the insulin types that are available, the onset of action, the peak action time to peak action duration, and the key use of that kind of so that will help you in deciding a proper regimen. Dr. Madhu was talking about adjusting the dosage. This is taking into consideration the pharmacokinetics of these different types of insulin preparation. I will not read out these, but generally please understand the rapid acting, the onset is within 10 to 20 minutes. Action lasts for 3 to 5 hours. Long acting Glargine, Detamir, the action lasts for 24 hours. So if there is any error with the dosing of this long acting insulin, the hypoglycemia, it is difficult to treat that hypoglycemia because it is a long acting insulin. So be careful about this. So also there are pre-mixed fixed ratio insulins are also available. So depending on the 30 70 50 50 mixes are available, where rapid and short this NPH are mixed together. So dual use peak is there, one for the plain and one for the intermediate. The duration is for longer time, so it can simplify the basal bolus regimen here twice daily, so it is less number of injection for the patient. Now, other thing that very important with the insulin products is this can happen because of the insulin syringe that you use. So you must be very there are different products which are available. U40, what does it mean? U100, U500. So this U40 stands for 40 units per 1 ml. U100 stands for 100 unit, and U500 stands for 500 units. So number lines in the patient should be taught to measure, use how they use these number lines and what is their meaning. So there are 3 different types of syringes available: 0.3 ml, 0.5 ml, 1 ml. Now 0.3 ml syringes are for 30 units. Then 0.5 ml syringes are for 30 to 50 units of insulin. Now 1 ml of a syringe is for dosing more than 50 to 100 units. So they are numbered at 2 units per interval. So then accordingly the patient can you can draw the conversions between the human and analog. So other challenges with this, as Dr. Madhu was showing, this is a hypoglycemia. is a augmented effect of insulin. This comes under class A adverse drug reactions. Class A means augmented adverse effect. This is just the extension of the pharmacological effect of the insulin. So the pharmacological effect of insulin is to bring down hyperglycemia to euglycemia. Now, if the dose is more for whatever reason, then it can go down to hypoglycemia. And this is one of the most life-threatening complication. Many of the patients who are not taught to recognize these hypoglycemia, or who do not recognize timely hypoglycemia and take measures, they may, I have seen, you also must have seen many patients going into coma for that reason. So immediate recognition and correction is important. Then I think hypoglycemia, various causes include side effect, less intake of food. Many patients, they take the medicine, they think that they need to take the medicine, but they do not, feel like taking full meal, or for vomiting happens, something. So they are fasting, So this can lead to this, or increase unusual, unaccustomed exercise can also lead to hypoglycemia. Alcohol intake, that is another trigger for hypoglycemia. Then poor injection technique, and of course the administration error and mistiming of the prescribed medicines, this can lead to. So about the management of hypoglycemia, somebody was also asking, if the sugar levels fall below 70 milligram per deciliter, usually the symptoms happen. In chronic diabetic patient, they may start getting these symptoms even below 100 milligram per deciliter. So usually less than 70 level, it is considered level 1. It is usually mild. Autonomous symptoms like sweating, tremors, headache, hunger. Individuals can self-treat. Sometimes may be asymptomatic in elderly with long-standing diabetes. This is called unawareness because of the autonomic neuropathy. So you have to educate these patients to recognize this. The treatment is 15 gram, 15-minute rule. If the patient is conscious, you give 15 gram of rapidly absorbing carbohydrate. It could be fruit, sugar, juice, candy, anything, and then you repeat the levels after 15 minutes. You can repeat this after 15 minutes. If the sugar levels are still not controlled, is not coming up, then you have to seek maybe glucose or glucagon injection have to be administered. Level 2 is when it goes below 54. Here, in addition to autonomic, patient has glycopenic symptoms like confusion, blurred vision, dizziness, difficulty concentrating, seizures, and loss of consciousness. Injection glucose is the treatment here. It should be infused rapidly. If conscious, oral glucose can help these patients. Less than 40 is severe. Patient is unconscious, requires urgent assistance, and it is life-threatening. Injection glucagon 1 milligram intramuscular. Or so sometimes if your levels are not available, if you have a doubt between hypoglycemia and diabetic ketoacidosis, choose to give 25% glucose. On recovery, identify the cause and treat and re-educate the patient accordingly. Now, this, as I said, errors may happen at any stage. Here, this is a handwritten prescription. The prescriber had prescribed 6 units of regular insulin. but the handwriting was such that it was read as 60 units of insulin, and this patient then developed hypoglycemia. So the way we write prescription is also important. Handwritten U can look like a 0 or a 4. So when it comes to writing dose of insulin, it is always recommended to write full in full UNIT, so that it does not get mixed up with the strength of the dose. And of course, for any medication, and particularly with insulin, the documentation is important. If you do not, the dictum here is, if you do not chart it, it did not happen. So be careful and document all dosages linked here. So now you were also asking about the questions about the management of hyperglycemia. I would, we already, as I told you, we already had these sessions earlier. You can watch the recording, or you can go through one of these standard treatment guidelines, our own standard treatment guidelines produced by DSPRUD. Last edition was in 2024. We had incorporated recommendations from RSSDI. Dr. Madhu was one of the contributor, consensus group member here. Then there was an update 2022. And even in our this thing, Dr. Madhu reviewed our guideline and we updated. You can also go through ADA, American Diabetic Association guidelines. If you like, Diabetic Standards of Care 2025 are out now. So any of these you can use, and for the management to know the pathways, how do you go, which patients to start with the oral medications, stepwise management is given, and then when to add insulin and where insulin is the first choice. All these things are clearly defined, and the glycemic goals, frequency of doing this monitoring, all these things are explained in these guidelines. So this will help you in improving the practice. Now, one more important thing, many a times, many of us think that insulin is not working, or you have to increase the dose again and again. I think many a times the reason is that the insulin, because this is requires cold chain, this needs to be refrigerated. If this insulin is exposed to higher temperature, or it is exposed to temperature lower than 0 degree, then the potency of the insulin is lost. So then also many patients have doubt about it, how to store the open vial and how do you store the unopened vial. So in this regard, we have been doing many these awareness campaigns going on our social accounts. We have Instagram account, Facebook account, and so we keep posting this. There are several questions, where to keep in the refrigerator. The insulin unopened vial should be kept in the middle shelf of the refrigerator, away from the vent and away from the food. Storing it in the door, temperature would be lower. So middle shelf is the most important. Then many times these patients are traveling, so they ask, how do you, so never, keep these medicines in the glove box or trunk, because these are high temperature area. Do not expose insulin to heat or freezing temperature, direct cold at any time. Unopened, for how long can you use the open vial? Usually it lasts for 28 days. Store open pens or vials at controlled room temperature. Many patients do this, they take the insulin out, measure it, take their dose and put the medicine back. There is no need to put the opened vial of insulin back in the fridge, because repeated thawing will spoil the insulin. Yes, but unopened insulin vial cartridge should be stored in the refrigerator. Also, then the insulin injection rules: use short needles as far as possible, explain sites where they can take this, and rotation of the sites is very important. Usually it is in the clockwise, 1 inch away, select the zone and 1 inch away, so that lipodystrophy is a very common side effect of injecting insulin subcutaneously. So you can avoid by rotating the sites, and then many patients pinch before taking the injection. There is no need to pinch, use these short needles, and it goes directly where it is needed. So there are, errors, do not shake insulin pens or vials except when it is, pre-mixed insulins, which should be gently rolled. Don't do the vigorous, and don't mix different types of insulin in one syringe, because if you mix, I'm not talking about pre-mix. If you mix regular with intermediate or they say, then the entire thing will become intermediate acting. So do not mix different insulin in the same syringe unless specifically instructed. Now, also, as I was saying, the insulin supply, please do take care of how the insulin is stored in the health facility. And also, many of us ourselves are diabetic on insulin, so we keep buying this from the pharmacy. So please look into it, how the insulin is sent to you. Many a times, if the pharmacist also does not know how to transport this insulin, they will send it like any other medicine. So it should be in the insulated box, but no direct ice should be there. And if they are using ice packs, then sweating of the ice pack should be done. Don't just place it on the frozen ice packs. That will again give a cool shock to the insulin. So please go through these, how to store this. Then while traveling, how the patient should be carrying this. Then monitoring and evaluation follow-up should be there with the sugar level. Ask the patient to maintain a diary, note the time and the levels, and if there are any hypoglycemic events that must be reported, adjust those accordingly, log all incidents and use them. Then at the same time, your role at a primary care level is to address there are many myths and misconceptions about diabetes. Many patients, they think, I don't take sugar, so I cannot get diabetes, or because diabetes is a silent disease, there are usually no symptoms. So many think that I don't have any symptoms, so there is no need to take medicine. Or there may be yet another group of patients who think that if their sugars are coming normal, they think it is normal, so they can stop it. So or other patient may think, I'm on medicines, I'm on insulin, so I can eat anything. So dietary advice, portion size, balancing, all these things. And of course, Dr. Nobajit talked about barefoot. These patients should not be walking barefoot. And then fasting. So again, I showed here some of the clips of our social media post where we dealt with all these things, aspects for public education, because medicine, of course, because diabetes is so common, and all of us are having diabetic patients in family, friends, and of course we see these patients at our clinics. So I think with this, you should be able to manage diabetes. Regarding the sessions on diabetes, you can watch the recording, and we'll try sometime to have full session on each of these aspects. Thank you for attending. You have the post-test link in the chat box. I think you can start doing it. And please
Thank you so
also
much.
feedback form also. Please post that feedback. We
Yes,
would
ma'am.
like to have feedback from you people regarding these sessions. If there are any questions, I'll be happy to take it.
Thank you so much, ma'am. I have shared the feedback link. I have also shared the post test and the link for the YouTube channel where you can access all the sessions for the all the series of STGs. Um, and also, if anyone has any questions, kindly post in the chat box. Ma'am, there are few questions.
Yeah, I saw that. There is a question about can diabetes be cured, normal sugar levels without any anti-diabetic drugs? Now, remember this type 2 diabetes, it could be drug induced, it could be idiopathic. So if it is drug induced, if you remove the cause, it will get better. But regarding the idiopathic one, the pathway for management is stepwise management. If the sugar, you can always start with the lifestyle changes, dietary management, nutritional management. So first 3 months of trials is given with the lifestyle modifications, and if the patient improves, it is okay. Otherwise, then you need to move to the step 2 where you need to introduce the medication. So many patients do well, especially the pre-diabetes patients, they do well with the lifestyle modification. So I don't know what do you, otherwise diabetes is not cured, is not a curable disease. You can control sugar levels and to bring them within the acceptable limits at which the damage does not happen. But I think those normal sugars without medicine is, early diabetes or pre-diabetic patients that they will respond. Any other question? I saw this only.
No, ma'am. Ma'am, is there any link for this public awareness IECs? If
Okay, I can post the link here in the you can follow us on our Instagram page. I'm posting this link here. You can follow us. Keep doing series on such topics: diabetes, hypertension, mental health. We've just finished with the mental health. Previously, we had done on diabetes, hypertension, various topics of interest, medication safety, fever management, like that. What all we are supposed to do, do's and don'ts. I have posted a link here, Instagram page link here. You can follow us here. Those of you who got the emails from us at my, below my signature, there are links for Instagram, Facebook, LinkedIn. So you can follow us on any of these. But for public education, I use this Instagram and Facebook. These based on this, you can share these with your patients, so it will help you in raising awareness about these issues. If any fellowship programs are available, yes, there are. I know there are two. One is from BMJ and another is from PHFI. They run these courses on diabetes. I think they do it every 6 months. So whenever there is a call, you can join them. Also, you can follow these standard treatment guidelines. The guidelines DSPRUD guidelines are comprehensive. We cover all diseases. There are specific disease-specific guidelines from the association side. You can go through that, but comprehensive will help you because this will help you in management of coexisting comorbidities because there are about more than 300 conditions that are given in the SDGs by DSPRUD. It is available online on Amazon.
Thank you, ma'am. The upcoming webinar will be on 16th August 25. It will be on managing common malignancies in district hospital and early detection of cancers at primary healthcare setup. I would like to thank you. Thanks, Sangeeta ma'am, our advisor sir, our ED sir, Dr. S.V. Madhu sir, and Dr. Navojit Roy sir for the very interactive session today. And all the participants were engaged till the end of the session.
Yeah, still there are 360 people
Yes,
sitting. I think it's almost 6 o'clock now. Navajit, would you like to say anything or just close?
No, madam. Thank you for the session. It was excellent.
These webinars, NHSRC, they are sending out this information to all their state, what do you call?
State
nodal
nodal officers, and also we share it in the groups of external assessors, internal assessors. And people are asking about the certificates. We will be sending those who have attended pre-test and post-test. We will be sending the certificates via email to them. They will receive within a week.
Yeah, ask for 10 days time. Otherwise, they will just keep writing to me. We also send out emails to all of to contacts of DSPRUD. Plus, I keep posting it on my WhatsApp groups, various groups. So I don't know how you got to know about this program. So just keep following that channel.
Also on LinkedIn and all the public health forums we are posting.
Yeah, I'm posting it regularly on these channels. Oh, okay. One more thing. The day is fixed. So even if you don't, hear, at least you know the third Saturday of the month. Time is also fixed, 3 to 6 p.m. Okay. Siddhi, is this the same link used every time, or you generate?
No, ma'am. We added a new link.
Okay.
But ma'am, we will try to send the link, like emails to everyone who has registered today.
Okay. That's another way of adding on to your contacts.
Yes, ma'am. Yes, ma'am.
Dr. Nobajit, there was one question about differentiating between diabetic ulcer and cancer. I don't know if you saw that. I just saw that. Maybe he's requesting to have a session on that.
Yes, yes. Well, that will need a biopsy for sure, madam.
Yeah.
That will need a biopsy. Yeah.
Clinically, it may look the same.
Yeah.
Thank you very much. Thank you all of you for sparing this evening. Thank you, Siddhi, Dr. Ranjit. Today I didn't see Dr. Ranjit.
Ma'am, he is here only.
I didn't see him. Okay. He's been, coordinating these sessions, talking to the experts, sending out this information to various groups. Thank you, Ranjit, for this. Thank you, Dr. Srivastav and Dr. Kotwal for supporting this initiative. Okay. Happy weekend to you, all of you.
Thank you, ma'am. Thank you, sir.
Thank you. Bye for now.